I'm on YouTube a lot. Some of the lectures are on there as well.
I know.
So
Yes.
yeah.
I've seen them. So
Oh, okay, wonderful. Thank you so much. Then thank you for inviting me. I'm honored to be here. I've met, of course, a lot of physicians in my life, but some of the smartest doctors are osteopaths. I don't know how you guys just got the smartest people there. A remarkable physicians. So I'm really honored to be here. And of course, integrated medicine, that's my passion, after having been traditionally trained. But realizing the lack of, just the inadequacies of the traditional approach. And stem cell therapy is a very inspiring field. And I think, the wave has been catching us on, partially because it's driven by people, by patients, because people are sick of not getting enough help, and they've heard of great hope offered by stem cell therapy. And that's where I've heard other doctors coming to me, wanting to learn how to do it because patients were asking them that they want it. So I think it's only wise that we are ahead of the game and understand enough about stem cells so we can properly consult our patients, and then give them the best possible treatment and the best way of treatment, of course, through proper training. So it's still a new field. So I'm excited to share some information. I've given various presentations on stem cell therapy. The first one is on choosing the proper source of stem cells. So that's kind of, fundamental before you go into anything else. So that's what I'm going to be covering, because I think it's still new information to a lot of doctors. We've all heard about stem cells. We heard about using your own bone marrow or fat, or use umbilical cord source, and what do all these mean? So I want to, cover that subject. I also have other presentations on anti-aging benefits of stem cells, on stem cell treatment for autoimmune conditions. So there are various ways of, looking at this aspect. I'm also a founder of the American Academy of Integrative Cell Therapy, where I do have an online course, and I also have a mentorship program. So if anyone wants more in-depth information and training, they can find me there. So it's aaict.org. I'll talk about at the end of the, the presentation. So I'm just going to open up a little bit. Let me see. I'll open up the screen share so we can get right into the the presentation. So anyone can see fine, right? I just want to make sure everything's working. Oh, I guess I just have to.
it looks fine.
Okay, great. So the topic is, are all MSCs created equal? Because I don't know if you know, there are various stem cell types, and stem cells, of course, are the original cell. First fertilized egg is the first stem cell, but there are probably 1,000 shades of gray, 1,000 different variations until the cell becomes a tissue-specific stem cells. But all along the lineage, they're all stem cells. But they have gained further function, but lost certain capacity. So they're becoming more specialized, and which means that they can't be as broad in how they can differentiate. So MSCs is a special group of stem cells where they are all over your body. Anywhere you have blood circulation, you have these stem cells that are kind of hovering over the blood vessels, waiting for the signals to arrive. If there's any inflammation, any injury, your body will send out signals. And these MSCs, mesenchymal stem cells, can traverse into your blood vessels and swim upstream to find the signal. That's why they're so powerful. That's why they were proposed to be renamed medicinal signaling cells, because that's one of the main functions, is that they will find the location of the signal and get out and start to send out, their own signals to the immune system and to the neighboring cells to promote regeneration. So they're considered the gold standard these days as far as therapy, because they're everywhere in the body and they have powerful regenerative potentials for the body. So there are all kinds of sources. And the topic of this talk is, what are the sources, and which one should you use as a doctor? So first of all, what are MSCs? So I talked a little bit, but in 1980s and early 90s, it was still believed that hematopoietic stem cells were the only stem cells existing in the adult body, right? Because in the 1960s, that's when they performed the first stem cell transplant, which were bone marrow transplant. No one knew at the time this was stem cell transplant, but later on they found out, oh, we were transplanting stem cells, but they thought that the stem cells, only stem cells left in the body were still in the bone marrow, and that was it. But in the early on, later on, 80s, 90s, and then they started to realize that there may be something else going on. Officially named as mesenchymal stem cell, MSCs is a new class of cells that do have the capacity to differentiate into different tissue cells, such as bone, cartilage, or fat. And supposedly they were able to be induced to form mesodermal tissues, right? So bone, cartilage, fat, the mesoderm layer. But we have evidence that they can form cells into into ectoderm and endoderm, such as neurons, liver. So they are able to cross different germ layers. And there are multiple names. They all come to MSC, marrow stromal cells. So anyhow, so there are all these different names, but Arnold Kaplan, who discovered these cells, wanted to rename them as medicinal signaling cells because of the way the cells are able to signal the body to heal. They were derived from pericytes, so perivascular. So they were all along the vasculature, and they can be isolated from every vascularized tissue. And every tissue specific stem cell, for example, liver stem cell or, cartilage stem cell, is sitting next to and in communication with a parasite or MSC. It's called MSC once it traverses itself into the blood vessel, but when it's sitting along the blood vessels, it's a parasite. So why are they important? So they have all these properties. Regenerative properties, also considered tropic property. So these are paracrine effect. What they can do is that they can home into areas of inflammation and injury and induce changes in nearby cells by secreting different growth factors and cytokines. They can induce angiogenesis, differentiation, or proliferation. They're very anti-inflammatory, so they secrete anti-inflammatory cytokines. In response to inflammation, they have immune modulating properties. They can modify or regulate immune function, facilitating T1 to T2 shift in autoimmune disorders, for example. They're anti-apoptotic, which means that if the cells are injured and are about to go on to program cell death, these MSCs are able to rescue them. For example, trauma, crush injury, chemical injury, radiation damage, or hypoxic injuries like stroke. Neighboring cells may be receiving signals that they need to die, even though they have not been themselves deprived of nutrients, but they may go on dying anyhow. But these mesenchymal stem cells can rescue them from that process. There's also antimicrobial properties that they seem to be effective against acute, chronic, and systemic infections. Actually, during COVID time, China was doing a lot of studies and using stem cells such as mesenchymal stem cells, and it have drastic, remarkable results. I remember in the very beginning of COVID, 6 different studies getting people out of the hospital within 5-6 days. These are people who are on ventilators. So yeah, they have, immune modulating, but antimicrobial. They have very interesting mechanisms of action. So, and I haven't even talked about on this slide of anti-cancer properties. So mesenchymal stem cells have been used to treat cancer. There are a lot of research around, but we'll talk about cancer later on as far as the differences between different MSCs. That's why we want to choose the proper source, because some sources are not ideal. And they also have the ability to elevate cellular energy. One way they do that is by transferring mitochondria. They can donate their fresh new mitochondria, especially if you get fresh new cells, such as the younger source. Then the recipient can receive more younger and more vibrant mitochondria, so helping them to function better. So these are some of the different mechanisms of action and why it makes them important. So if they're everywhere, are they all functionally equivalent? That's the question. So you can get it from bone marrow extraction, or you can get from liposuction. Liposuction came on board later on, and bone marrow extraction was much earlier. These are very much popularized by the orthopedic surgeons. They're still the biggest fan of bone marrow extraction because early on they realized, oh, if we break a bone and the marrow leaks out, things heal up really nicely. So that's how it was started. And liposuction became very popular as well. A lot of overseas locations, they spin it down when they extract the fat. So you can see the top layers of fat, and then you have a little pellet on the bottom after they spin it. That's the stromal vascular fraction. That's containing a lot of adipose-derived stem cells. So one question is, if you choosing either getting it from a person's own or from a younger source, does age actually matter? So I'm going to present to you some evidence, really because I delved deep into this question because I wanted to give patients whatever that's the best. Whatever that's going to be the best is what I'm going to devote my resources and energy into understanding, and learning and implementing. So before I started doing any stem cell work, that's what I just went on a deep dive. Does age matter? So the fact that we live a long time and we carry with us all our cells, especially stem cells, because they stay in our body for the entire time that we're alive, right? We're running out of stem cells, but the ones that are with us have been with us since we were born. So that means everything that we do, every alcoholic drink we take, every NSAID we take, and every medication, every terrible preservative additive we have in our food, every toxic exposure we have had, EMF, you name it, stress. So everything can tear the cell apart in a way, right? In a sense, can cause damage to DNA. So they do carry with us. So not only they can lead to cell death, they can lead to cell senescence, loss of regenerative functions, or even cancer transformations, changes. And when you have neonatal stem cells, such as from Wharton's jelly is a component of the umbilical cord tissue, right? That's the gelatinous material that's wrapping around the arteries and vein. Those are spared from these pro-aging factors. So I want to show you some evidence of why age matters. So for example, the first one, aged adipose-derived MSCs are significantly compromised in their ability to support vascular network formation. And they were looking at cutaneous wound healing, how well the wound can heal. And when they used these adipose-derived stem cells, they realized, oh, they weren't able to rescue these age-related impairments. And then when they use bone marrow-derived MSCs, they also have less ability to form new muscles and less ability to engraft, stay in the area and develop in comparison to developmentally early MSCs. And bone marrow-derived MSCs exhibit age-related decline in inflammatory response in their cytokine and receptor expression. That's important for the migration of these cells and the activation of them and their ability to exert immunomodulatory actions. So which means, the older you are, the older your bone marrow stem cells are, and the less capable they are to mount these responses, to migrate and be activated. So some other evidence, genes related to senescence also start to increase in adipose-derived stem cells. So you get more senescence going on. And aging alters the availability of certain cell types. So this is important cell type, CD34, very much sought after, but it decreased the availability of these cell types and decreased their angiogenic potential. And as cells age, for example, in aging bone marrow-derived stem cells, they have increased the level of reactive oxygen species. And not only are they have more of these reactive oxygen species, these older cells are also more sensitive to these reactive oxygen species, impairing their effectiveness. So double whammy, they have more of these elements that are causing damage, and they're more sensitive to them. So they just, they get more weakened over time. And age matters. Some other evidence that when they were using young stem cells from a person 1 to 5 years of age, compared to older stem cells from somebody that's age 50 to 70, they realized that when they try to help somebody recover after MI, the younger cells were much more effective at helping the helping recover or improve the cardiac parameters. And MSCs from young individuals can undergo neuroectodermal differentiation in vitro, but bone marrow-derived MSCs from an elderly patient cannot do that anymore. So you're losing capacities. So all these, every one of these little excerpts is from somebody's careful study, right? These are not arbitrary. And then adult MSCs are exposed to lifetime of factors, including, certain anti-inflammatories we take, a lot of people pop them like candies, and even just even just NSAIDs, it may inhibit MSC's ability to form cartilage and disrupt bone formation from these cells. And some more evidence. So lifestyle factors do affect MSCs. They were looking at mice. They were feeding them either high-fat diet. They were feeding them high-fat diet. And then the adipose-derived stem cells from high-fat diet mice showed higher, potential to form fat cells and lower potential to form endothelial cells, so endothelial differentiation. When compared to control group, so the high-fat diet is changing how these cells are able to differentiate. And if you're looking at obese patients, looking at their stem cells' ability to form bone, so the mineralization nodules are fewer and smaller. So the obese patients' stem cells are just not very, they're not as good as forming bones, which is part of their job. And metabolic diseases like diabetes can alter the environment of these stem cells and diminish the cell's ability to establish vascular network in vitro and in vivo. So metabolic diseases can affect how the stem cells work. So if you're extracting stem cells from a diabetic patient, then you have to understand that these are not suboptimal stem cells. Especially knowing how prevalent diabetes and obesity is in our country. And if you look at perinatal stem cells, so this is just to refresh your memory. This is the placenta with umbilical cord, and there's the maternal surface. If you're getting cells from the placenta, they're usually a combination of the mother's and the baby's stem cell. But if you're getting cells from the umbilical cord, then these are all baby's stem cells. You don't have any cells from the mother. And this is one reason I'm choosing to use umbilical cord as a source. And that's, so far considered the most potent. There are a few people who dissent, but the consensus generally is that umbilical cord is the superior source when it comes to birth tissue. And here's just a cross section of the umbilical cord. Here you have the amniotic membrane, and then you have the Wharton's jelly. That's protecting the arteries and vein. And this is where you can get cells from the blood that's floating around in the blood vessels, or you can get cells from the Wharton's jelly, which is full of mesenchymal stem cells. You can even get cells from the amniotic membrane, which is also full of mesenchymal stem cells. Even though they're all mesenchymal stem cells and all from the birth tissue, still, it doesn't make them the same. So these comparison between the tissue cells and the blood cells. So cord blood cells, you can get cells from the cord blood, and you will have majority of these cells are mononuclear cells. So they're primitive immune cells. And some are, about 1% are hematopoietic stem cells. So they will, of course, regenerate all the blood cells, right? You can have white, red blood cells from the hematopoietic stem cells. And cord tissue, on the other hand, that's full of Wharton's jelly, has huge percentage of mesenchymal stem cells. And this is important because even people who are doing cord blood transplantation, they are talking a lot about mesenchymal stem cells. But the cord blood composition is very similar to the bone marrow. The bone marrow has about 0.01 to 0.1% of mesenchymal stem cells. So all those cells in the bone marrow, very small fraction are actually mesenchymal stem cells. So cord blood also have similar composition, very few mesenchymal stem cells, but doesn't mean that hematopoietic stem cells are not helpful and useful, or the mononuclear cells. But it's true, the gold standard is the MSCs. And it's also true, a lot of cord blood companies only talk about MSCs when they have they have very few MSCs in their product. So I want to give you a direct comparison. So this is a comparing between umbilical cord blood MSCs versus bone marrow derived MSCs and adipose derived MSCs. They were comparing the growth profile, the cellular senescence, and anti-inflammatory properties. So let's look at the growth profile. How well are they able to proliferate? So the bone marrow and adipose derived MSCs, their growth stops at passage 11 to 12. So the passages is when you replate the cells. So the cells will be on a petri dish. When it gets confluent, filling up the dish completely, that's when you move on to the next passage. So at passage 11 to 12, that's when the growth just stops. Whereas umbilical cord blood derived MSCs, which are much younger, they have quite a few more passages left, right? They have more life in them. And the growth rate, the cord blood MSCs have the highest rate by just how fast they can double their population. And the adipose derived MSCs have the lowest rate. Clone genicity, so how much of a clone can you form? So they will plate these cells on a petri dish and see how many colonies can form. So the umbilical cord blood MSCs form the most, and then the bone marrow, and then the adipose derived. And then there's comparison of their senescence. So there's a particular measure called gall staining, looking at this particular senescence marker. The umbilical, so at passage six, the umbilical cord blood derived MSCs have no senescence, doesn't show up, but the bone marrow and adipose derived stem cells have shown some of these senescence markers. And then these senescent expressions,
Hello?
these senescent expressions increases drastically from passage 9 to 12, but umbilical cord MSCs are still remaining at the lowest level. And there are also other senescence related proteins that during progressive passages, the umbilical cord blood MSCs have the weakest expression, whereas the other two have much stronger expression of the senescence. And if you look at their anti-inflammatory properties, so there's a model for inflammatory, this LPS-induced inflammatory model. They were looking at umbilical cord blood MSCs comparing to bone marrow and fat-derived MSCs, and it showed that cord blood MSCs significantly downregulate inflammatory cytokines in comparison to the other two. And it secretes much higher level of anti-inflammatory protein, which is closely associated with upregulation of anti-inflammatory factors. So this is nice is because it's direct comparison. And here are some other examples. This is in orthopedic cases. So they found out that umbilical cord derived MSCs produce 3 times as much collagen as bone marrow derived MSCs. And then umbilical cord derived MSCs showed greater mineralization in a culture that was supposed to, help with bone formation, right? So it has better ability to form bones and better ability to form cartilage, chondrogenic pellets. So they're just more effective when it comes to these functions that they are supposed to perform. And some other comparisons, this is really interesting one. So they were actually looking at umbilical cord blood-derived MSCs versus adipose-derived MSCs. They were looking at their effect on glioblastoma. So they put it in a petri dish, put these cells next to cancer cells, and they put it on live animals' body. And in both cases, when you put umbilical cord blood-derived MSCs next to glioblastoma cells, the cancer was inhibited and they start to shrink and go away. But the adipose-derived MSCs actually promoted their growth because they keep growing and they just, get bigger. So this is one reason I think it's important for providers to know. If you are wanting to give your patients the safest and most effective treatment, you really need to look at what has been found. Umbilical cord blood-derived MSCs induces apoptosis through this trail ligand. And the umbilical cord blood MSCs express these this ligand much more strongly than adipose-derived MSCs. So that's one of the mechanisms. And Wharton's jelly MSCs do not induce teratoma and do not induce tumors. And Wharton's jelly derived MSCs are not associated with enhanced growth of solid tumor, can even help you get rid of certain solid tumors. So they found out in breast cancer, ovarian cancer, osteocarcinoma, the evidence is that Wharton's jelly derived MSCs can help you get rid of cancer. Some other comparisons. This is about angiogenesis. Wharton's jelly derived MSCs have expressed more angiogenic factors. They are more immune regulatory, and the Wharton's jelly also have stronger expressions of these growth factors known to have antifibrotic properties. So they can be used to reduce and prevent fibrosis and scarring. And I've seen that a lot in my own clinical practice, which is super fun because how many things in medicine actually can break down scars and can really have truly antifibrotic properties. So it's very exciting when I give people IV stem cells and their testicular nodules go away, or their thyroid nodules go away, or their liver nodules go away. I mean, it's amazing. Or their COPD drastically improves, getting off oxygen. So these are all what's inspiring to me. And I think, as a doctor, if you haven't been using stem cells, you really owe that to your patients to consider bringing that into your practice because you can reduce so much suffering. Wharton's jelly's MSCs are able to induce endothelial cells to migrate more effectively than bone marrow derived MSCs. So, all these different aspects of how they function, we've seen again and again. These are all different studies from different scientists from different parts of the world, all showing similar conclusions that these younger stem cells have a lot of superiority in comparison to the older stem cells. Some other comparisons about when it comes to neuroprotection. Wharton's jelly derived MSCs secrete factors that have better neuroprotective effects than those from bone marrow MSCs, and they're more effectively decreasing cell death and apoptosis. And the gene expression patterns also shows that Wharton's jelly MSCs have a tendency to, basically they show more gene expression tailored toward cell proliferation, neurogenesis, nervous system development, and blood vessel development. Whereas bone marrow-derived MSCs have a different set of skills, they're more tailored toward ossification and skeletal development. So even though they're all called MSCs, and they, when you stain them, they all have surface markers. Yes, I can name them MSCs, but they're drastically different, right? If you get something from a really young, early source, like Wharton's jelly, I just want to remind you guys, Wharton's jelly is formed when the baby is getting formed, right? It's during embryogenesis. So a lot of these cells are actually trapped in the umbilical cord when the fetus is forming. So they're very, very young. They're so young that they're in between the baby stem cells and the embryonic stem cells. So a lot of surface markers that, that are no longer present in the baby stem cells are still present in these Wharton's jelly stem cells, in these MSCs. So very different. Like I said, it's like 1,000 layers of evolution of these cells. So there's no distinct demarcation when the cells become wood. It is life is a continuous stream. At the very end of the stream, that's the tissue-specific stem cells. Yes, now we come to the end stage. But before the end stage comes, there are all these gradations, 1,000 shades of gray. So, so the Wharton's jelly MSCs contains a lot of these early potentials, these powerful potentials that have been lost as the person develops and ages. And I want to talk a little bit more about the primitivity. So I mentioned, that these cells from Wharton's jelly, they have high expression of embryonic genes. So these are all the embryonic genes that are still present, but no longer present in the older sources. So that makes them somewhere in between embryonic stem cells and adult mature stem cells. So when we say adult stem cells, a baby is an adult in the embryological term. So when we get stem cells from the baby, even though the baby is 0 day old, that is adult stem cell. So which means that these cells are just more primitive, but without the risk of embryonic stem cells, because embryonic stem cells, because they haven't been proven, how many pregnancies actually result in life healthy birth, right? How many things can go wrong? When you have a new embryonic stem cell trying to make a person, lots of times there's genetic defects, there's little things can go wrong, and it doesn't make it. So when you try to use the cells that's really close to that stage, you really haven't proven yourself that you can form a full human being. All your genes are functioning perfectly, that you can make a perfect symphony. So you haven't proven that. And then you are trying to use that and give it to a person. Yes, sometimes it can form a teratoma. But when you use something from Wharton's jelly, when the cells, this is after a baby has been born. The baby has been formed. All the genes pretty much work. And everything, the jigsaw puzzle has been fitted together. And now you're using the cells of a proven product, right? And when you use these mesenchymal stem cells, even though they have embryonic markers and they're very potent, but they've been proven and they no longer can form teratoma. So that's no longer a risk. And more about umbilical cord stem cells as far as differentiation. So the Wharton jelly MSCs and the whole umbilical cord derived MSCs have the best osteogenic potential versus the umbilical cord artery, vein, and umbilical cord lining MSCs. So this just shows you that even within the cord, not everything is the same. So there's a lot of nuances. And the Wharton jelly MSCs can differentiate into heart cells, right? Heart muscle cells, neurons, glia, oligodendrocytes, and hepatocytes, in addition to the traditional bone, cartilage, and fat cells. And then more about the umbilical cord MSCs, the gene expression. So look at these different compartments: amniotic membrane, chorion membrane, and umbilical cord. So deriving from each of these different components, there are different genes that are upregulated. The amniotic membrane MSCs are more upregulated when it comes to cellular growth and proliferation. The chorionic membrane more toward cardiovascular, hematological system development. And the umbilical cord MSCs more toward nervous system and behavior. So, yeah, the umbilical cord, right?
Hello?
Yeah.
Dr. Kang, is there a difference between ossification and osteogenic potential? I'm referring to the previous slide.
Yeah, it's a very similar. It's referring to the same thing. Yeah, so this is, okay, me showing you this. This is, I'm giving you an idea why actually, when I use a stem cell product, I actually use a combination. I use cells from the amniotic membrane, cells from the umbilical cord tissue, and I use cells from the umbilical cord blood, because as you can see, different components, have different upregulated genes, right? Then I can really give the patient more breadth of potential for healing. So, so that just kind of give you an idea of why, where my philosophical, my philosophy come from. And when you look at autologous stem cell transplant, right, from a person's own bone marrow, fat, you can get it from menstrual blood, dental pulp. Yes, it's a perfect HLA match. And there's a higher chance of long-term engraftment. That's very true. When you put the cells in the body, the cells can differentiate and there's less chance for your immune system to attack. That's absolutely true. But the caveat is that when we do stem cell transplant, the engraftment is actually a very, very tiny fraction of the picture. The majority of the benefit we get from stem cell therapy is not from engraftment, it's from the endocrine or not the paracrine effect. So that's from the signaling effect. Because if you read any articles from the last 15 years about stem cell therapy and how the stem cell treatment worked, almost all the article, they would, a lot of them would test to see if the final repaired organ actually have the new cells in them. We'll see if they were the descendants of the stem cells, and almost always none. So, I mean, it's become a mantra from these articles. They say, well, obviously, the result of the benefit, the clinical benefit, is not from the fact that these cells differentiate into local tissue cells, it's from the paracrine effect, it's from the signaling effect. So it's been proven over and over ad nauseum. So now it's an accepted fact, although some doctors still don't know. They still think that I need to put cells right into that organ I'm trying to repair. No, you don't. First of all, the cells have the ability to be attracted to the area of injury and inflammation. Second of all, when they get there, they will send signals. So your own stem cells can differentiate and can start to replenish the tissue. You don't need these cells to be right there. So that's the, the so-called advantage of autologous cells. I don't know how much advantage there is if we don't need the cells to actually stay and be a perfect match. But there are a lot of disadvantages. So first of all, it is invasive and inconvenient. I actually published an article with Dr. Smiler on maxillofacial surgery using the stem cells that I use, which is umbilical cord derived, of course. And when that was mixed with a bone matrix, that can promote, drastically improve the healing of the bone. So that was the article. And before he started using the perinatal source, the umbilical cord source, he was doing bone marrow transplant, basically extracting bone marrow from the from the same person. And he's done that for over 30 years. And what he realized was that people came back, they complain more about their hip pain than about their dental pain, because, it was just, it's painful, it's very inconvenient, and it's invasive. And also just remember, when you cause an acute injury like that, especially if you're trying to help something that's systemic, if you put your cells into the IV line, the cells are going to be attracted to the injury you just made. So a lot of cells are going to go right back to try to heal the drilling in the bone that you just made. So there's something to consider. So it is invasive, it's inconvenient, and there's also quality control issue, right? These are done in physicians' offices. They take your bone marrow or fat out and they're processing it. These are not GMP labs. We all know, each other, we are doctors. We're not bench scientists. We don't have that kind of standard and capabilities. And with age and disease, the quantity and quality of stem cells decline. So the red bone marrow would change to yellow marrow as one ages, and there's toxic buildup in adipose tissue. Just so you know, MSCs decline with age. When we are born, every 1 in 10,000 cells is an MSC. When we reach our teenage years, it becomes 1 in every 100,000. So it's from 10,000 to 100,000. When we reach our 40s, it becomes 1 in 400,000. When we reach our 80s, it's 1 in 2 million. There's no way around this. As we live, more cells senesce and die, and we lose them, and that's it. We lose, the amount, and then we also lose quality, as I've shown you. So stem cells are less potent, shorter telomeres. They're less versatile in their differentiation capabilities, and less inflammatory, with less neuroprotection, senesce more rapidly. And they also have less concentration of growth factors in the transplant product. And of course, the cells are attracted to areas of injury, and it's very difficult to achieve frequent and regular dosing. How many times can you drill and do liposuction on a patient? before that becomes just, extremely cumbersome. Especially if you want to do anti-aging treatment, that's pretty hard to do anti-aging using your own old cells. So what are the disadvantages for perinatal stem cells? So possible immune response, yes, there's potential, especially if you have very little MSCs. If you just use cord blood, which have very few MSCs, there are more chances that a person will get shortness of breath, will get some chest congestion, some malaise, sniffling. So all these are possible. All these I've seen. The reason I've derived at the product I'm using was because I've used everything else. So I've used cord blood products alone, and that's one of the problems, is because they have so few MSCs. But stem cells, these young stem cells, they do have some HLA markers. The HLA-1 marker is actually very important. They mark your cells as human, so your own immune system is not going to attack it. And the HLA-2 markers are immunogenic, but there are very few expressions of these markers, these HLA-2 markers on stem cells. So using somebody else's stem cells, yeah, there's potentially less chance to engraft. But then we now know the main mechanism of action of these cells is not through engraftment, but through paracrine effects. And what are the advantages? So there's actually no matching necessary. I'll tell you something that's really fascinating. When you do bone marrow transplant, if you transplant between two perfectly matched, so-called matched, that's matching all the HLA markers we know about, right? But how many we don't know. So a perfectly matched donor, two adults, you give to another adult, there's still a chance of rejection. But if you give the person umbilical cord blood transplantation, remember the cord blood is very similar to the bone marrow composition. So if you give umbilical cord blood transplant and you do absolutely no matching at all, there's still less chance of rejection than if you use perfectly matched adult bone marrow transplant. So that's how drastically different young versus old. The younger have more ability to adapt to a new host. So the cells are more primitive, they proliferate faster with more differentiation potentials, and they contain more pluripotent stem cell populations with more embryonic characteristics. Cells are more potent, right? Secrete more growth factors, have longer telomeres, less accumulated genetic changes. They have more abundant growth factors, right, more types, and more of these growth factors that are associated with use, and they're also easy to obtain with no ethical controversy. So what's special about umbilical cord tissue? I was telling you about the high MSC content in the cord tissue. So up to 1 in 300 cells are MSCs, whereas cord blood is 1 in 2 million, right? So they're just very, very few. MSCs are more primitive from the umbilical cord tissue. They have pluripotent markers. So these are, pluripotency, which means you can go across germ layers and becoming cells of any tissue type. And they have more ability to develop into cardiomyocyte or neurons and are more neuroprotective and angiogenic. And here's a quick overview of the tissue source comparison. There's the placenta, umbilical cord, or autologous. So you can look at the number of cytokines, growth factors, and total cell count. So there's the amniotic membrane. So a lot of people use amniotic fluid. As you can see, there's almost no cells. Pretty much, the FDA considered it a acellular product. So yes, you're giving a lot of growth factors, but you're giving no cells. But if you use umbilical cord blood, which has a high cell count, but very few MSCs, versus cord tissue, the cord matrix has, not so much cell count, less, but a lot of MSCs. So an amniotic membrane, very, even less cell count, but a lot of MSCs. So the product I use combine the three, right? Amniotic membrane, cord blood, and cord tissue, all three of them. So not only you have a high cell count with different cell types, but you have a lot of MSCs. And also I want to talk about native versus expanded cells, because a lot of your patients may already have thought about going to Panama, going to Mexico, Colombia. They want to get these cells because they were promised that they were going to be given 200 million, 400 million stem cells. This is a presentation I attended one of the conferences. So somebody actually studied what happens when you use these cells and looking at their clinical, at their, the efficacy they were able to produce. So looking at cells that are not MSCs as control, there's not much clinical effect. And when you use 100 cells, 10,000, these are native MSCs, which means they haven't been expanded, which means that they haven't been grown in the culture, in a incubator. So they're not allowed to start to make duplicates of themselves. So these are native, pure MSCs without expansion. 100,000 cells, 10,000 cells produce this level of benefit. And when you use 100,000, which is 10 times that, you produce a dose responsive, dose response relationship that you're getting a higher amount, higher level of response. But when you give 10 times that, but these are expanded cells, these are actually cells that have been growing in culture. Even though you're giving 10 times, you're having less of a benefit. So more is not better. So that's something I'm trying to educate my patients. I just treated a 9/11 responder who went to Mexico, Tijuana, to get the treatment. And he had a lot of lung pathology, brain fog, all kinds of problems. He did get relief 3 months after the treatment, but he had 3 months of extreme fatigue. And it's not just him. When he was there, there were 20 other patients that were all there, and they all connected with each other. So they were corresponding with each other. Every one of them had extreme fatigue for months. So everyone. And then a month ago, he came to my clinic to get the treatment. Very simple treatment. I didn't tell him not to exercise, not to do this and that. But anyhow, so he was able to get quick response. His lungs was doing better very quickly, absolutely no fatigue. And he said it was night and day. So that just goes to show when you give people expanded cells, not only you're decreasing efficacy, you're also causing potential reactions, which I think is some kind of immune reaction, because you are allowing the cells to differentiate, to express surface markers. Then these cells ended up showing, the markers of who they were. Then you're causing rejection because they've senesced, they in a sense have matured, became more adult-like cells, then you're causing rejection. So there's a big difference. Maybe after seeing this, you will feel, better able to console your patient about the risks they're taking on by going overseas. In the US, when you start to expand the cells, the FDA says then you're producing a drug. Then you can only give these cells to a patient under a clinical trial, which is why all these companies have left the US and they set up shop overseas where there's no such restriction. But I think there's good reason that the FDA said that. So that's that. That's the entire presentation. So my goal is for physicians to be well educated on the differences between these MSCs and why they're powerful and how you can pick the best one for your patients so they can get the best results. Yeah, so I am gonna stop here.
I have a question. We're treating a patient, FSHD, fasciohumeral scapular muscular dystrophy, and we managed to halt more or less his muscle breakdown, and we're dealing with the scar tissue, and we think we may have found a way to recruit satellite cells. But my question is, would stem cells or their signaling mechanism help to recruit the stem cells which are inactive in muscular dystrophy patients?
I'm not sure. So I think muscular dystrophy is still a tough condition to treat.
Yes.
You can transplant cells in that area, but I don't know if there's enough inflammation in the muscular dystrophy region, in the dystrophic region to actually attract the cells. I don't know if
Well,
there's.
all of the regions in this gentleman, well, everything from his neck into his pelvis is inflamed, and that is where the scar tissue comes from. It's in a sense, it's an inflammatory disease, but a genetic one.
Mhm.
But you don't know what
Well,
the
if there is
actual
inflammation involved, I
signaling
definitely.
mechanisms do.
I think if there is inflammation involved, then definitely there's a good chance. When I consult with patient, when they ask me, doctor, can stem cells help this, can help that? I always go for research evidence first. But a lot of times no one has studied that particular condition. Then I look at the mechanism, the
Yeah.
pathophysiology of the person, right? I'm not going to be able to fix the genetic defect for sure. That's gene therapy, but I
Oh,
can
yeah.
fix the downstream effect, which includes tissue damage. So if there's tissue damage, inflammation, immune dysregulation as part of the picture, I think stem cells has a good chance of helping it.
Okay, that's what I wanted to know. Thank you.
Yeah, good luck. I hope you let me know how the patient does. Anyone else have any questions?
Hello.
There's a question here. Do you have any experience using stem cells in relation to cancers?
Releasing a cancer. So actually have a I've been talking about this a little bit. I no longer consider it a contraindication. When I first started doing stem cell therapy, I was not touching cancer patients, but well, my mom had cancer, and that didn't prevent me from grabbing stem cells and bringing it back to her in China. But the problem is, I mean, she was already getting better from lymphoma. Unfortunately, the doctors persuaded her to take chemotherapy, 3 days after the stem cells. So that killed her. But nowadays, I think if somebody has cancer, if they get proper consent, I'm happy to share it in consent form with you guys. Then you will have, and I think there's a chance that can really help them, not only helping boosting their own immune system to fight the cancer, but also have direct anti-cancer benefits. So, but just be careful. If a person's going through chemotherapy, avoid giving your stem cells really close to time where they're getting chemotherapy. I usually want them to finish chemotherapy, give it at least 4 half-lives of the chemo agent, so that it's pretty much out of the system before you give stem cells.
Okay, great. Okay, anybody else have any questions? Comments?
Yes. Hello.
Yes.
Yes. Hi, Bill.
Hi there.
Dr. Kong, great lecture. Thank you. Learned
No,
quite a
thank
bit.
Well, good.
Actually, my question, several of them, but let me go backwards. As you were talking about the expanded MSCs, so is it no matter the generation, you still have the same lack of effect? Let's say, in other words, you spoke about the 11 to 12 generation, 14 to 16 generation. Let's say they take the younger expanded MSC. Is there a possibility that they have more effect than the older one?
Well, the younger, I mean, it's tug of war, depending on how young the cells are, how many generations you have. I don't use expanded cells unless I can be guaranteed that there's less than 3 generations. Unfortunately, all these overseas companies expand them to huge number of generations. So they're very much, I think, compromised in their quality. But yeah, but all I use is first generation, right? Never been expanded. And when I give the number of stem cells, that's 1/10 of what overseas companies are giving. I think I'm getting, at least as good, if not better results. So to me, there's no need to give these expanded cells.
Right. Makes sense. So the earlier question that I asked you about, let's say, ossification versus osteogenic potential, it's because there's one of the slides you mentioned that, what was it again? I think you mentioned that the bone marrow MSC, they tend to ossify, and later on you spoke about the Wharton jelly MSC, and you spoke about osteogenic potentiality. So I was wondering whether, on the one hand, whether there is a difference, and you told me there's no difference. Basically, that's basically the same thing. But from your experience, is there one that is more likely to go toward ossification? That's one of the questions that I had. And then, is there a potential side effect, for example, calcification of soft tissue, stuff like that?
I haven't seen calcification of soft tissue. Actually, MSCs have been shown to have great benefits for atherosclerosis in breaking down, you know, the calcification, the lining, and enlarging the aortic root. So that's not a concern of mine. Most of these MSCs should have osteogenic potential. Of course, if you use younger and umbilical cord derived stem cells, they will have stronger capabilities to form bones.
All right, thank you.
You're welcome.
Okay, John, you got anything for us here for Dr. Kong?
Sorry, I just think, thank you, Dr. Kong.
You're welcome.
Wonderful information. There's been so many of the A4M crowd that have been working with this for what, 40 years?
Oh, wow.
So it goes way back. I don't know if you know Dr. David Steenblock, is it?
Yes,
Bill?
I do.
What a guy, huh?
Mm-hmm.
So he was leading the way many decades ago, and it sounds like you're leading the way now. So I congratulate you.
Thank you very much. We're all trying to do our best. Yeah, so if anybody is interested, you know, I put on my email. I don't know if you saw, just joykongmd@gmail.com. You're welcome to email me. I'm happy to, you know, one of the most fun thing to do is to work with other doctors, you know, who are, you know, pioneers, who are, you know, open-minded, and to really bring something new and powerful to patients. So yeah, I'm happy to talk with any one of you if you're interested in, you know, the training or, you know, utilizing the product that that I put together, because I've seen all kinds of products out there. And one reason I started my own stem cell company was because I mean, I really had no interest in getting into business. I just wanted to give people a really good product, but that has been very difficult because most companies are started by business people, and it seems like the bottom line is profit, not science and quality. So anyhow, so initially I wanted to provide good quality, but then I realized that I could tweak the formula and make it more potent and more complete. And that's where the, you know, the product came about, where you can incorporate different components of the birth tissue. Yeah, so I'm happy to talk with anybody who wants to look into it.
Thank you.
There,
Have you given us some contact information? I didn't see anything in the chat.
Yeah, so it's okay, let me put in the chat. Let me see, where's the chat? So, okay. So I'm gonna put my email here, joykongmd@gmail.com. And then the academy is aict.org, which is very helpful because as a physician, you cannot post testimonials, which is really strange because the FDA or the medical board thinks that if you're posting testimonials, that means you're making a claim. So, you know, with the Academy is really helpful because all the case studies are posted on the Academy site, and the Academy is not making claims. The Academy is just reporting what has been happening with different patients. So you can utilize that if you're a patient with, let's say, rheumatoid arthritis, with lupus, with osteoporosis, you know, with cardio, you know, with MI. You can go on there and see if there's any case studies that's already reported, and you can share that with your patients. So it's very helpful, and it also protects you.
okay, there is another question here. Do you give stem cells during a flare of an autoimmune disease or wait for the flare to be over?
I give it during the flare. Actually, they've done research showing that when you have an acute inflammatory episode, it makes the cells work so much harder and better. So I used to think that, you know, we want to reduce the inflammation. Now it's like, it's fine. You can be as inflamed as you want, and let's just get the regeneration going.
Okay. I would think that's the whole purpose of what you're doing in the first place, right? So that wouldn't
Yeah.
that would make sense to do it during the worst of it.
Right, exactly. Yeah, no need to suffer first. And just, yeah, let's just start now.
Okay, you hear that, John?
I hear,
No need to suffer, John.
I hear and I believe.
Okay, so we have your email address, and of course I have it if anybody needs it. We will send you, if you want, when we're done, the contact information for everybody that was here.
Okay,
Anything that you'd like to share with them, you'll get to do that. Okay.
okay, wonderful.
I can't thank you enough for being with us. I know you're very busy, and we sort of shanghaied you out of the blue, but we'd love to have you back again, for part 2 down the road a piece. And anybody have any their experience with the stem cells, exosomes too? You use exosomes? Is that part of your repertoire or no?
Yeah, we produce exosome product as well, but I used it more like an adjunct because I always say stem cells are the mothers of the exosomes. So if I can give the mother that lives a month to 3 months, rather than giving something, the progeny, which is just little particles that will go in and dissipate, the effect only lasts for 1 to 3 months. But if you give stem cells, which lives for 1 to 3 months themselves, and then they will continue to secrete more targeted exosomes as they go, and you will have much extended time of healing. So that's why stem cells generally, their effect lasts for 3 to 6 months rather than 1 to 3 months as in exosomes. But I do use exosomes as adjunct to stem cells because they are, you're giving a lot of information all at once. And for people who have acute inflammation or have central nervous system conditions, then these exosomes can cross the blood-brain barrier very easily. And you can, it's much easier to target the brain. So high inflammation and brain conditions, I add exosomes.
Okay. Just as a reminder for everybody, the videos will be on aosrd.org/webinars. It's also been showing up on YouTube for some reason. I don't know why. I don't put it there myself, but a lot of them have ended up there, and under my name for some reason. And I have following. I have over 1,000 people as in the channel, which I don't even I don't know how it happens. So
it got away from you. Okay.
So we are the font of misinformation here. So and we're sort of proud of it too. So what about mixing either the stem cells or the exosomes with a PRP? Is that
I'm a big fan. PRP is like nutrition, food for the stem cells. For local tissue injections, I almost always mix them together. So not only will nourish the cells, will give you added benefit, but also will give you volume for migration, right? If you inject into soft tissue like the back, the diffusion, if you give a tiny bit of stem cells, it's going to stay in that area. But if you give more volume, then it's going to have a better fraction of, capability of diffusion. So for several reasons.
There's a question, the delivery system, do you like IM, IV?
Yeah, so that's the art of it. I am pretty heavy on IV use because there's a lot of research, using IV therapy, and I think IV produce more profound benefits. Not only it can be attracted to local areas, but it also interact with your immune system, which have more profound benefits, which can be shown in the case of people who has stroke. At the same time of a splenectomy is a very strange, a strange way of occurrence. But people who had a stroke at the same time got a splenectomy initially actually have less infarct size, which is because the immune system is not involved in bringing in all these white blood cells and all these neutrophils that actually cause more damage. But over the long term, you do need your immune system to heal. So when they look at the infarct size, like 3 or 6 months down the road, the infarct size is the same between people who have the spleen versus don't. But this just to give you an idea of how much the immune system is involved in local damage. So I think when you bring your immune system on board, you're going to have more drastic healing.
Okay. Can I give you a scenario and maybe you can give us your thoughts on it? So like 66-year-old male, he's had an L4, L5 disc issue and an L5S1. He's had 4 surgeries that have failed, and the surgeon wants to go in and do a 5th one now. So he showed up in my office and we discussed all of the things we've been discussing here. What would be your some recommendations under that scenario, or what other information would you need?
So say it again. So you want to,
So I got an L4, L5, L5S1. He's had multiple surgeries that have failed. Severe pain. Is barely able to. He's had a lumbar fusion also. I forgot that. And he's barely functional. And the family wants to know is there any what else can be done?
yeah.
So in your world, stem cells, exosomes, PRP, we'll
Can
look.
definitely be helpful, but I do think that the back issues are a little bit more complex. I don't personally inject into the facet joint or the intradiscal space, but you can certainly do that. And there has been some positive reports, but mainly what I'm doing is address the fascial layer that most of the back pain comes from, actually the inflammation, the fascial layer. So I tend to address that, but for further, more, targeted injections, there has been some positive results. So they can certainly try to inject stem cells right into.
You're using fluoroscopy, I take it, or ultrasound guidance, or
Yeah, for those injections, you would need to do that, and I don't have that capability.
Okay. So if you're doing, say, a shoulder joint, are you using any
No, I'm just using anatomical landmarks. Yeah.
Okay.
But I was trained by an orthopedic surgeon, so I think he knows what he's doing. So I've had some good successes.
I'm just asking because there's this big push to everything has to be done under sort of fluoroscopy or ultrasound guidance and things like that. So
You could if it's more for show for the patient.
Okay, I know we're dealing with somebody very honest here. I've done about maybe 1 million parafacet injections, and I've resisted the radiation and the showmanship with and the increased prices as well. So, can I just simply ask, if you're doing parafacet injections without forcing into the joint, have you tried that and have you had success?
No, I've only done paraspinal muscle injections. I didn't, yeah.
Because even with the anatomy, the anatomical placement, you can bullseye that facet every time. That's not a problem.
That's great.
And we have great success. But I'm doing some patients now with post-surgical, just like Bill said, and we're going to hit the facets and we're ready to do that. So I'll be in touch on that because I want to see what happens. I think it's a difference between a wheelchair and not. Want to walk, and I'm hoping that the stem cells and exosomes can be of great benefit. We're going to try it.
Yeah.
I'll let you know.
It's certainly a lot more potent for sure than PRP. Yeah.
are you going to be at any of the upcoming shows or conferences? Do you do the in
I
Vegas?
haven't done A4AM yet. I mean, as a presenter, but I will be presenting at there's an ozone conference. I presented at Schallenberger's conference just this year, and then I'm presenting another ozone conference in Santa Barbara in beginning of November. But yeah, haven't looked further. But if you guys have conferences, I would love to come present.
Here you go, John.
Terrific.
We'll be in touch if we ever get our act together here.
So you haven't had a conference yet?
It's a long story. We've had them in the past, but it's a long story. I don't want to go into it.
Okay, all right. Whenever it happens.
Okay. All right.
All right. So my contact info is there, and I look forward to hearing from wonderful. And thank you for the kind words about my presentation.
Thank
I
you so much.
appreciate you guys. And I'm always impressed that, you guys must be some of the most dedicated doctors, late at night after a long day in the clinic, and then still listen to, these technical presentations. So thank you for being here.
Well,
Thank you.
we're the fantasy football losers, so
All right.
okay,
Thank
so
you much.
thank you.
Yeah, thank you, everybody. Okay, take
Just
care. Great meeting you all. Bye-bye.
next week we have Emily Rowe, and she's going to be speaking about oxalate. So something I don't know. Some of you know a lot about, some of us don't know nothing about. So we'll learn all about oxalates next week. Okay. So if you want to do, are you on our mailing list, Dr. Khan?
I'm not. I'll be happy to be on it.
Okay. I'll make sure you're there. Okay.
Okay, thank you.
Thank you so much. And we'll be in touch.
Okay, wonderful. Thank you, Dr. Clearfield.
You. Okay.
Okay, bye-bye.
Okay. John, did you leave? I guess he left too. Okay. Okay, everybody. Thank you so much. We'll be here next week, same time, same station. Anybody have any comments or questions? Thank you all for being here. Some of the newer faces. Dr. Janot, thank you for being with us. Thank you for your questions. Please return. Are you on our mailing list?
Yes, I am. But I'm quite a few, but I'm back again.
Hey, don't be a stranger.
No, not at all.
All right. Oh, just to let you know, so October 18th, 19th, I'll be in Houston, and also the 22nd for AMMG, Age Management Medical Group. They got me doing a simple introduction to male hormones. That's on Thursday. That's their workshop, and then I'm doing non-hormonal ways to manipulate hormones that's on Sunday. So I go through as far as I'll get it, all the way from testosterone through prolactin, how to increase testosterone, how to decrease testosterone without using testosterone, estrogen, progesterone, insulin, growth hormone, thyroid, DHEA, pregnenolone, all of them. So we always put that at the end of our conferences. Oh, by the way, you can do this. So this is going to be the oh by the way, whole lecture. So you'll have you'll have ways. So I have 20 ways to raise testosterone, 20 ways to lower testosterone without using it. So, we have a lot of our colleagues either can't prescribe it or don't feel they're confident in it. So that'll be my presentation. So, okay, so that's Age Management Medical Group, agemed.org. And that's October 19th through the 22nd. If anybody else is presenting anything, please let me know. And we're always open for anybody to present their ideas here. We're non-CME, so you can present your ideas. You can use trade names like Dr. Kong did. We have, we'll send you the contact information after the show. And if you have any special offers and whatnot, you can certainly, offer that out. Anybody else have any comments or questions? It's good to see everybody again. Dr. Dalton's been a while. Again, don't be a stranger, and please let us, give us, if you have any ideas about what you'd like to hear, please let me know. We're going to have coming up in the future, we're going to have Dr. Patel is going to give us some insight on how to begin environmental medicine evaluation. We've got coming up shortly too. Okay, so thank you all, and we'll see you again next week, same time, same station, 8 o'clock Eastern, 5 o'clock Central, 5 o'clock Pacific. You can always get me, where to find me, whenever. So, okay, thank you all, and we'll see you again.
Bye. Take care.
I'll have this up. I'll have the video up as soon as I can, usually within 24 hours on our website.